This is a case of right complete staghorn calculus, right kidney, planned for the right supine PCNL. The first step is marking the posterior axillary line and the lateral border of the paraspinal muscles, along with marking of the tip of the 12th rib and the anterior 12th rib and 11th rib if necessary, and inferiorly the border of the iliac crest. So this is the area where we usually take puncture, and sometimes we may need to take puncture in the supracostal area or intercostal area, and supine PCNL helps you to do that well. And these are the lithotomy rods, and the right side is helped with an extension rod, and the left side is a normal position. There's an instrument tray with mini nephroscope, the 18 French nephroscope, 24 axis seat, and the facial dilators and the screw dilators. So this is the positioning of the patient before placing the bolsters. We can see the posterior axillary line is almost not visible. So this is after placing the bolsters. You can see the posterior axillary is well visible and the area of puncture is well seen. These are the two bolsters placed, one below the posterior chest wall and one below the hip. The RGP is being performed. So before taking the puncture, we have to assess the line of access along the direction of the calyx to a good calyxal puncture and decide the puncture point. Your stab incision. Now pass the needle in the direction of the predetermined direction horizontally, no oblique, upward, downward, anything, just pass horizontally, reach the tip of the calyx you decide to puncture, and then make finer adjustments up or down. And this is a 0-degree puncture and no need for the 15-degree or 30-degree moving fluoroscopy towards the surgeon, or we don't need any cephalad or caudal positioning change of the fluoroscopy. So only upward and downward, as anterior or posterior adjustment, that's enough. So in this case I took 2 punches and the third puncture was successful, aiming at the lower calyx. So it is always desirable to pass the guide wire down into the ureter. It will be safe if the guide wire passes into the ureter. So with the puncture needling position, make a stab incision around 1 centimeter wide. So to avoid the damage to the glide wire, the puncture needle is in position before stab incision. The first step is passing a facial dilator. Always use screw movements and not don't use force actually. If you use force, the wire may buckle and it may create a false passage in spite of the wire is within the system. So use just screw motion and just go inside. So the third, after passing the screw dilator, we will be going for the Alkin's rod, central rod, and the standard 24 size Amblat's dilator over the Alkin rod. Then over that we will be putting an Amblat sheet 24 size. So always don't push too much into the system. Just stand where just close to the calyx, just very close to the stone of the branches of the stone. And in staghorn calculus, sometimes you may not find it a free flow of urine, but okay, some amount of urine coming out is a good sign, but sometimes you may not find it. But anyway, just pass the scope, because under dilatation is safe in staghorn calculus rather than over dilatation unless it's a well dilated system. So with guide wire in place within the access seat, now we are going to pass the gauging French nephroscope. So you can see we have not entered the system, but the stone and is visible, and just following the guide wire will reach the stone. And now you make the fine adjustments and push the ampullage seat under vision safely and reach the stone. Now just break the stone using high frequency, high power, and get some space, and just again push this ampullage into the system. And during this process, you may have some amount of bleed, but nothing to worry. So when you go into once you get entry in the system, the bleeding stops, and you can do the case without any compromise in the vision. The thing is, don't over dilate and the problem is you may enter the system on the side of the stone and damage the infundibulum, and so the infundibulum may bleed, and that may obscure the vision, and sometimes you may need to abandon the procedure and come back later. So always underdilate, try to underdilate, then over dilatation, and stay there, and then with help of nephroscope you can place everything in the system. As long as the guide wire is there, nothing to worry. So this one is being broken, and the good thing is that we can access almost all calyx except the parallel calyx and the line of puncture through the SupinePCNL, and even the mini scope will help you to manipulate well fall into the upper middle calyx too. You can have a safe upper costal puncture also in this case if necessary, and reach the lower pole, and vice versa from lower pole to upper pole. So it's easy pole. But for other, but in SupinePCNL, the easiest calyx that can be punctured is the middle calyx. I can say that middle calyx is the darling of the SupinePCNL. It always stays in the line of puncture, and I think it's easy to puncture the middle calyx rather than the upper and lower pole. But it depends upon the stone load and the type of the stone, and we have to choose the calyx so that we can give a maximum clearance. Thank you. Stop video. Stop. ഞാൻ ഇത് കൊണ്ടുപോയി stop.